All right. Good morning, everyone. Thank you all for joining us for what is the last 2022 Equitable Care webinar from the Washington chapter of the AAP's Equitable Care Committee. Today, we will be talking about reproductive justice, and I'm going to have a brief introduction of our Equitable Care Work Group, now committee, and then Dr. Asante will introduce our speaker, and then we will have a wonderful talk on this. So I'm Dr. Kathleen Kieran, along with Dr. Asante. I am the co-chair of the Equitable Care Committee for the Washington chapter of the AAP. And we have quarterly equitable care webinars that are available to focus on pertinent issues that are relevant to pediatricians and all those who care for children. Can I have the next slide, please? So as I mentioned, we have our agenda. We'll give you a quick background on the Equitable Care Committee and Toolkit, and then get on to our webinar. Our presenter today is Dr. Aisha Mays. Next slide. All right. The Equitable Care Committee was formed in 2020 in response to the National Reckoning on Racism. WCAAP and its members collaborated to establish a toolkit which is available online, also in print form. And the goal of this toolkit was to support clinics and healthcare providers to provide equitable care, make healthcare more welcoming and responsive to families of color, to deliver high quality care to the diverse patients and families in Washington state, and to make this widely available on the toolkit, on the website, as well as in a printed form. The toolkit is periodically updated, so the online version is up to date. And Ariana, I don't know if you could put the link in the chat. We usually do that as well. But this was a tremendous undertaking and really something that we wanted to do so that people could not just talk about disparities in care and inequities in care, but actually do something about them, take those first steps. Could I have the next slide, please? So as I mentioned, Peter and I are the co-chairs of this committee, previously a work group, but we absolutely could not have done it without this absolutely stellar group of people who provided us education on the 4 different buckets that are in the toolkit. You can see them here: provider education, physical space, safe and effective care, and promoting EDI and in healthcare. But this is really an all-star group for anyone who knows any of these people, and very lucky that we had these people volunteer to be part of our committee and do this work. Next slide. I will turn it over to Dr. Asante for introduction.
Good morning, everyone. I have the privilege of introducing Dr. Aisha Mays this morning. And before I do that, I just wanted to let people know to feel free to put questions and comments in the chat. And then feel free to send me direct comments and questions as well, especially if you prefer that I read out questions de-identified. That's absolutely okay as well. And we want to hold questions until the end of this talk. And with that, Dr. Aisha Mays is a family medicine physician who focuses on adolescent medicine. She's a founder and medical director of the Dream Youth Clinics of Roots Community Health Center in Oakland, California, and a clinical researcher with the UCSF Bixby Center for Global Reproductive Health. Dr. Mays is an innovative adolescent health care leader and has special clinical teaching and research experience on youth affected by sex trafficking. Her interests also focus on providing quality adolescent family planning within a reproductive justice framework, and on elevating the expertise of young people who choose to parent as a way to shift the national paradigm on young motherhood. Dr. Mays believes that passion, creativity, critical inquiry, and building community are keys to dismantling inequitable systems and constructing a new vision for the future of healthcare. And with that, I will stop talking and let Dr. Mays get on with this incredible talk. All right, thank you.
Thank you so much, Dr. Asante, and thank you to the Washington chapter of the AAP for having this this webinar series. It's so important as continuing education for all of us in healthcare. So thank you so much for having me, and I'm excited about this talk today. So I'm going to go ahead and share my screen. Can I do that now? Okay. Okay, thank you. I'm going to share my screen. Sorry for all of the traffic here. Okay, and let me know if you all can see that okay. Okay, so today we're going to talk about reproductive justice in adolescence, and this is a very extensive topic, reproductive justice, and I'm so happy that we're talking about this as we are catching up with our reproductive justice leaders. Healthcare is catching up, and those of us who care for young people and children, we've been farther behind. So we are in this moment of really catching up and talking about how we center reproductive justice for young people. And so we're going to be talking about paradigm, policy, and praxis today. And I'm going to, this will be interactive, and I'm going to also move swiftly so that we have enough time for our questions at the end. Okay, so I have no financial interest or disclosures in this talk. And so today we're going to be talking about the principles of reproductive justice. We'll talk a little bit about the historical and the present reproductive justice landscape as it applies to young people. We'll talk about highlighting just the importance of centering reproductive justice principles when providing adolescent care, and then we'll also demonstrate and just have some examples of how this has been incorporated in my clinical practice throughout the country, other best practices. And again, I'd like for this to be interactive. I want to hear you all's voices. I know that there is a lot of expertise in the room, and folks have different experience with this, so I would love to hear your experience as well. So just a little bit about the reproductive justice framework. Folks can feel free to either put this in the chat or come off mute. So when we think about reproductive health versus reproductive rights, reproductive justice, let's just ground ourselves in some of the definitions here. So when you think about reproductive health, what comes to mind when folks say reproductive health? What are some of the things that come to mind when you hear that? And you can feel free to put things in the chat, or you can come off mute. And so when we think about reproductive health, we really think about the service delivery framework. So it really is providing the services, the healthcare services that we all go to medical school for, the training that we do, being in residency, really providing those services, that healthcare delivery system. And then when folks hear the term reproductive rights, what comes to mind? Anything that comes to mind when you hear about reproductive rights? You can feel free to put things in the chat, or you can come off mute. When we hear about reproductive rights and think about reproductive rights, we really think about the legal framework. So the legal or advocacy-based framework that ensures that people are able to have certain rights given to them around their reproduction. This is what many people think about in terms of the advocacy work that started in the 1960s and the 70s, the women's rights movement, really, again, those ensuring that individuals have rights to bodily autonomy and to being able to care for themselves. Some of the criticism around the reproductive rights movement as it was in the 1950s, 60s, and 70s is that it really centered white middle-class women and really left out swaths of the community that not thinking about the barriers and obstacles that they're having around those rights. And so there's been lots of criticism around the reproductive rights movement, although there was movement there, but that movement really centered one section of the community that really was more privileged and affluent to begin with. So when we think about reproductive justice, what comes to mind when folks think about or hear the term reproductive justice? So as we think about reproductive justice, again, reproductive justice is really a holistic movement building framework that really looks at and centers on what are the oppressions and obstacles that people experience and are having to live under that threaten that rights, that threaten the rights-based framework that we think about, that threaten them being able to actualize their reproductive health. It really is looking at the multiple systems of oppressions that people experience that then limit them from actually stepping into those reproductive rights and actualizing the reproductive rights that have been given them under the legal framework. So the term reproductive justice, this term was coined in terms of the framework, was coined in 1994 from 12 Black women in Chicago. Again, this was a framework that really further contextualized reproductive rights, recognizing that not all individuals are able to actualize rights simply through a legal-based framework, but really that we need to be looking at all the systems that impact individuals and may limit them from actualizing those reproductive rights. It really focuses highly on intersectionality, a term coined by Kimberly Crenshaw, which looks at the individual systems of oppression when they are combined together in an individual having individual systems of oppression that are combined together, and that compounding and having even greater systems of oppression that they are having to contend with. And really, the reproductive justice movement is a human rights framework. So reproductive justice is a human rights context. It's not just a healthcare context, but it really is something that everyone should be able to actualize. And so again, this is another way of looking at it. So we think about reproductive justice. It is both reproductive rights with social justice. So really that the social justice systems that we are looking at and that we are interrogating, because we know that those are the things that are affecting individuals being able to actualize those reproductive rights. And so when we think about the reproductive justice core principles, and so I'm going to take a look at the chat because I see that folks are putting things in the chat. When we and do folks know and people heard about the core principles of reproductive justice? What are the things you think about when you hear reproductive justice and those core principles? Okay, and I'm sorry I can't see the chat. So if folks are saying things in the chat, if someone wants to come off mute. So when we think about our first core principle of reproductive justice, it's the right to have a child. So we think about this human right framework is also centered in rights. So the right to have a child, the right not to have a child. So recognizing that individuals should be able to make that choice. Either I'm ready to have a child or I don't want to have a child at this moment. The right to parent one's children in safe and healthy communities. So again, this is that expanded view, really looking at this high level view of like, it's not just about the right, but are you in a place that's safe? Were you able to make a safe decision about those rights? And then the fourth principle, which is we talk about this more newer in reproductive justice movement, is the right to dissociate sex from reproduction. So again, the sexuality is not just about having children. It's not about just about your fertility, but also thinking about sexual pleasure, sexual consent. So the right to dissociate sex from reproduction. So again, as we look at all these rights, we're still talking about rights, right? So where does the justice come in? Where does the reproductive justice come in? This is, again, not just about rights, but it's all the things that can then threaten those rights. And so when you see these lighter green bubbles, this is the reproductive justice piece. So how does social equity impact these rights? How does bodily autonomy impact these rights? How do equitable healthcare services impact these rights? How does anti-discrimination impact those rights? So these are the things that we're thinking about. So again, if this is a social justice movement, it's really focusing on social justice and human rights. And so as you all continue to learn about and think about reproductive justice, I want you to be thinking about it is these higher level impacts, the things that actually affect people be able to actualize the rights that legally they've been told that they have. So we would be remiss in all of this that we did not talk about and pay homage to our reproductive justice leaders. So Loretta Ross is one of the pioneers of the reproductive justice movement. She just won a MacArthur Genius Award this year around her work with the reproductive justice movement and the framework, and has spearheaded much of this work with those other 12 Black women in Chicago in 1994. And we also want to uplift Sister Song, the Women of Reproductive Justice Collective that was created in 1997 by women of color, Black women, women of color, trans women, non-binary women. And so again, really looking at reproductive justice from this holistic sense of all women and female identified persons who experience systems of oppression that impact their reproductive health and their reproductive rights. Oops. And so again, this is leading up to really reproductive justice is for everyone. So it's not just for Black women. Yes, it was created by Black women, but it's not just for Black women. It really is looking at all individuals who experience systems of oppression, who experience challenges being able to actualize their rights. And so we work with young people. So we know that young people are a very unique group that experience challenges in accessing the medical system, and that includes with their reproductive health. So again, reproductive justice is for everyone. And reproductive justice matters to young people. We know that young people are also helping to lead this work. This is from Advocates for Youth. They have a reproductive justice arm where they are mobilizing young people to really, again, talk about the systems of oppression that young people experience, and really working at the intersections for advocacy that is designed by youth and for youth. And so I would just want to bring in some youth voice into this talk. And so this is a study that myself and a medical student of mine did in 2018, where we looked at talking to young people affected by sex trafficking and wanting to learn about what are the reproductive health obstacles, challenges, that they experience, what are some of the facilitators that they experience. And they talked about reproductive justice in their reflections. So this one young person talks about health system equity. So she says, is our reproductive system equal? No, it's not. Because I feel like if you go where money is, you can decide on what you want to do. Like if you can't have a baby, but you've got money, they try to make you have a baby. Like, you feel me? So again, this young person was talking about the impact of money in our systems and how people are treated better when they have access to money, or when they are perceived to have access to money. And this young person talks about abortion access and poverty. So she says, youth want free access to reproductive health care, can't afford it. But I think it's like abortions and how some people can't afford abortions and why they can't afford them. The P word, poverty. So again, young people, we weren't even talking about reproductive justice in this conversation, and young people were talking about it. So they understand that they also are experiencing systems of oppression that limit them accessing their reproductive rights. So as we continue to think about this today, I want you all to think about how reproductive justice principles are applied to your work with your adolescent patients, with your clients. I want you to think about that. And I also want you to think about how they're not being applied to your work with adolescents, and how some of these principles and these rights may make you uncomfortable, may make your health system uncomfortable, may make your clinic leadership uncomfortable. What are some things that you want to be thinking about, and what can be improved upon as in this work? So we're going to take a deeper dive into reproductive justice in adolescence and talking about these principles. And the first principle we're going to talk about is the right to have a child. So just really quickly, just around the history of pregnant and parenting adolescents, and this is a whole talk in and of itself. So excuse me that we're going to go a little bit quickly, but we know early on in history, in the early 1900s, there was a different acceptance and framework around pregnancy adolescence. We know that women started parenting at an earlier age in their adolescence. It also often was connected to being married, and really, so you see these pictures here of young women being married, and the values that were upheld there were really around marriage. at a young age. And then around the mid 1900s, around the 1950s, we saw a shift in the narrative of adolescent young motherhood, and this vilification of young mothers, calling them wayward girls, unwed mothers, even using the term teen mothers. We saw this shift happening as we saw more a decline in marriage for young mothers. So as we saw this decline of young mothers being married, we also saw this difference in how young mothers were talked about. And throughout history, we see a very different narrative for as Black girls are talked about in terms of being pregnant or parenting, and we've seen that Black girls have really been uplifted as really a trope around young motherhood and pregnant and parenting adolescents. And so we look at some of the data just over, again, since the 1950s overall. Teen pregnancy and birth rates have continuously declined. We have seen a dip, but in that decline, we've seen that Black and brown girls have been in the highest spectrum of pregnant and parenting young people, although birth rates across the board have declined. And so if we look at adolescent birth rates and marital status, so that again, this graph on the far right is really looking at the marital status. So again, since the 1950s, the marital status has declined. So again, we don't see that young people who are pregnant and parenting are not getting married at the same rates. And then somewhere around the 1980s and 90s, we saw a flip. So where more young people who were pregnant and parenting were not married versus the ones that were married. And so when we think about that, as we think about the narrative and how the narrative has shifted around the vilification of young people who choose to parent. And so this is just a timeline. And again, looking at this again, so overall, we see adolescent birth rates have been decreasing over time, and that we still see that Black and brown young people have the highest adolescent birth rates over time. And so then we want to think about and kind of interrogate where this narrative is coming from in the context of what's been happening. So we think about kind of the politicization of reproductive health care. And we think about it, if you look at young people who are pregnant and parenting, that has also been highly politicized. So the bubbles at the bottom, these brown bubbles, we look at what's happened in politics over time and how the framework of the politicization of parenting, pregnant and parenting has happened as we've seen birth rates increase and spike. So we've seen, again, lots of policies that have happened between the 1960s and even up until the year 2000, and how that has often mirrored increased birth rates, increased pregnancy rates, and what's also happened in the legal framework, where young women have been offered to more public benefits if they use Norplant. So again, that's a long-acting birth control that's not currently on the market, but that was very popular in the 1990s. And also how women were offered decreased penalization around the legal system if they used Norplant. And again, these policies. So, and we also sort of look at how young women were, the support the young women were given. So if you look at this, the orange arrow up top, and we look at young women in pregnant and parenting schools, all along, young women were also either being asked to leave their school of origin when they're pregnant or parenting, or they had to go to a pregnant and parenting school, which didn't focus as highly on education. Certainly gave lots of information about pregnant and parenting, but not around education. And so again, pregnant youth have also been highly politicized, and overall, a system of political violence, gender-based violence, structural violence, family and community violence, and really racism. Because again, we see who are the young people who are getting pregnant, who are the young people who are parenting. We're really looking at parenting lots of Black and brown girls. Public health messaging, we also look at that and see kind of how that was very effective in the vilification of young people who choose to parent. And really was successful in withholding support from young people who choose to parent. And this was not just happening in the South. Really, this was happening also. This is a campaign that happened in New York City in 2016 from the New York Department of Health and Human Services that, again, vilified young people who used to parent versus providing support for pregnant and parenting young people. This graphic on the right was from the National Campaign to Prevent Teen Pregnancy, which is now called the Power to Decide. This also was a campaign that also looked at really vilifying young people who choose to parent. And we know that young people are still parenting. And so we want to bring in some young youth voice here. And so we talk when we speak to young mothers. This is a qualitative study on young motherhood in 2006 that looked at young motherhood. So this young person says, I definitely have a more positive outlook on life. A lot has come out ever since I had a baby. This other young person said, I used to think of it as a mistake. Now I call him a miracle. Young people also have goals. I do see myself having a good job, a good house, my dream house, and having a husband, and we would be a team, and we wouldn't have to struggle or anything. And I can see her, my baby, being happy, and I want that to happen. That is my goal. So we know that young people who are pregnant and parenting also have goals. They also want that support as well. And then if we look at the second principle of reproductive justice, the right not to have a child, there's been a lot in the political landscape recently around this. So we're going to talk a little bit about this as well. So if we look at just the policies around this, so a lot was happening in the 1970s around minors' rights to privacy, to contraception. Title X started in the 1970s, where minors could access contraception independently, STI services independently, pregnancy counseling independently. So again, being able to actualize their rights not to have children. The legalization of abortion happened in the 1970s, and we're going to talk about where we are now. So again, this is history. But if we look at these policies in action, we know that we still see restrictions around these policies if we actually look at them in action. Currently, 19 states only allow certain minors to independently consent to contraceptive services. And so these certain minors are often minors who have children, minors who are pregnant. So again, not all minors are able to independently consent to their own contraceptive services. 18 states allow physicians to inform parents when a minor is seeking sexual and reproductive health services. So we think about how that also limits a young person's ability to seek services if they know that their parents or their guardian might find out that they're seeking services. And then currently 36 states require parental involvement for abortion services. So we've talked a lot about parental notification laws, parental consent laws, and how that can really negatively impact young people actually actualizing that right to not have children. And so specifically talking about abortion. So let's talk a little bit more about the post-Roe landscape, because we are right in the middle of it. So this just happened. And so if we look at nationally, about 50,000 young people are in need of abortion care annually in the US. And so we know that this is high, the Roe being overturned is highly going to impact young people. We know since the overturn of Roe, 15 states have had a near complete abortion ban. And so we have been talking about how this directly impacts young people. And recent data that's come out from We Count, which is from the Society for Family Planning, show between April and August, just this year, that we've seen 10,000 fewer abortions since the overturning of Roe. And so again, we know that Roe was overturned in June, but we know that they were leading up to this around this time. And so again, we've seen this, and we know that youth will experience some of the greatest impacts of this, because we know that youth are very vulnerable to abortion restrictions because of the limitations that they have, because they are young people and that they are minors. And we know that, again, with the abortion bans and with abortion restrictions and the overturn of Roe, those who are the most marginalized will always are the most affected. So when we look at this, we know that overall Black youth will be the most affected by abortion restrictions. We know that youth of color, other youth of color would be affected, youth living in poverty, LGBTQ plus youth. And again, we talk about this intersectional oppression. So we know that Black LGBTQ plus youth, Black youth living in poverty, and will always be the most impacted, because those are the young people who are experiencing the most marginalization in general. In general, we know that young people have less access to, globally, have less access to finances, to economics, to transportation. And so we know that young people will be some of the most impacted groups from abortion restrictions. And so when we think about the impact in liberal states, so I'm in California, I'm in a so-called liberal state, you're in Washington state, you're also in a so-called liberal state that has a wider access to sexual and reproductive health care services for young people, wider access to abortion. But we also know that liberal states will also be impacted. So when we think about the impact in our liberal states, what might show up? We are concerned about access. So we know that people are going to have to come, and we're already seeing that folks are traveling from states that have higher restrictions to states that have wider access. And so we want to make sure that we continue to have access in our so-called liberal states for people. But we also think about, what is the influence? How is this national influence going to be influencing our individuals locally? How are providers, how are systems in our quote unquote liberal states being influenced by the national conversation? And how might that lead to discrimination on the individual level for young people? How might that lead to misinformation? Again, this national rhetoric, this national misinformation, and how that trickles down and bleeds into our liberal states. And so when we think about the third principle of reproductive justice, the right to raise one's children in healthy and safe communities. So when we think about healthy young families, so again, how are we supporting young families? How are we supporting young people to raise their children in healthy and safe communities? This is where we are probably doing the worst as a nation. There is high stigma for young people who have children. And so we think about, how does that stigmatization then impact them being able to parent safely, impact them being able to find jobs in childcare? And how does that lead to societal marginalization? And then how does that societal marginalization lead to community disenfranchisement? And again, this is how it impacts healthy and safe communities overall. How does that impact and lead to really overall structural violence? The young people who have children, young people who choose to parent, have to live under and threaten really the health and safety of them raising their children in the community. So again, this now impacts generations. So when we think about young mothers and how they talk about healthy communities, this again was a study that we did in 2017 with young people. And this is a photo voice study with young people. This is a young person who says, I don't want my son to be raised in this environment. I'd be scared to walk home when I get off the bus. Somebody could have just shot someone. That could have been him. So again, our young people are thinking about that. They are also worried about how they are not able to raise their young people in healthy and safe communities. So how do we center reproductive justice in practice? How do we do this for our adolescents? So when we think about prioritizing reproductive justice in healthcare, again, we do this from positive youth development framework. So it goes really beyond reproductive choice. It goes beyond rights. We really have to engage young people in a positive way. And so what we recommend is, again, positive youth development. And so a positive youth development framework, which actually which partners with young people, focusing on their strengths, focusing on their development, focusing on what they want to be successful in their lives. And us as providers, we are the facilitators, but they are the leaders. It is inclusive, it is universal, it's community-based, and it's collaborative. When we think about the first principle of reproductive justice, how can we do this? Well, we can support young people who are pregnant and parenting. This is a graphic from my clinic, the Dream Youth Clinic. We have a program called Young Mothers Rising, where we support young people who decide to parent. We have created a holistic program for them, provides parenting support, education support, one-on-one support for them and their young people, and lots of resources. When we think about the second principle of reproductive justice, we want to support young people who want to prevent pregnancy. One way of doing this is providing equitable and open contraceptive care and counseling, shared decision-making. I'm sure you all have heard about that. We actually are partnering with young people to hear about what they want for their contraceptive care, and we are following their lead. Another way for doing this is supporting young people who want to end a pregnancy. So again, we want to be aware as providers around the abortion landscape. We also want to advocate for our young people for access. So these are two resources here. The Repro Legal Helpline that provides information about abortion restrictions per state. So you're up to date on how young people can access abortion in their state, and also the judicial bypass. So again, these are, again, for their utilizing states that really have high restrictions to abortion. But it's also important for us to know in our quote unquote progressive states and states where we have access. The third principle, supporting young people to parent in healthy and safe communities. So again, this is a photo from our Young Mothers Rising program. Again, spending time with young people and young parents and really advocating on a broader level to dismantling this structural violence that young people have experienced that actually impact the safety of their personal safety, the safety of their children, the safety of their communities. And we really do this work, again, as providers, we need to do this work through community partnerships. We can't do this on our own. We need to do this in community supporting young people. So just in summary, this is a quote that I just really love from, this is an OBGYN, Dr. Higgins out of Wisconsin. She says, one of the tenets of reproductive justice is recognizing that the main reproductive challenge facing young and poor women of color is not unintended pregnancy by itself, but rather socioeconomic and cultural inequalities that provide some people with easier access to self-determination and bodily autonomy than others. And I feel like that just really sums up how reproductive justice and how we actually separate that from reproductive rights. And then this is one of the sheroes in my life, Audre Lorde. I've learned so much from her and putting her words into my practice, that there's no such thing as a single issue struggle because we do not live single issue lives. And that is really the hallmark of reproductive justice. It really is looking at all the systems of oppression that individuals experience that threaten their reproductive rights. And so this is just a slide of some resources that you can take with you. And I'm happy to share this slide as well as you all continue to learn about reproductive justice and apply that to adolescents. Thank you so much.
Dr. Mays, that was an incredible presentation. So thank you so much for your efficiency in giving us such incredible information. I had a question about the conversation around sort of using a reproductive justice lens and the conversation around contraceptive counseling. And I know that there's been a lot of discussion about and some data that supports that there might be some coercion on the part of providers, and we're talking to youth of color with respect to counseling about LARCs. I guess I wanted to ask, how can we take a much more equitable approach to make sure that we are not accidentally doing harm to our patients in that manner?
Yes, thank you so much for this question. And we've talked about, we talk about contraceptive care so much in working with adolescents, and our national bodies, the AAP, SAM, ACOG, have put out their recommendations on the standards of contraceptive care for adolescents. And in 2017, we were we were all excited about with LARCs and having LARCs for young people and putting out these different recommendations that all young people should have LARC first. And we realized in studying that we saw reproductive coercion go right in there, hand in hand, where we saw Black and brown young people really being offered LARCs at higher rates than other young folks. We saw this being infused into our Title X clinics, which mainly takes care of young people who are in poverty, Black and brown youth. And so we saw the disparities show up pretty starkly. But we also saw that there were recommendations for tiered-based counseling. So I didn't show that graphic, but I think we've all seen the beautiful bedsitter graphics that show contraception on as we look at how effective the methods are. That's tiered based. We look at the most effective method first to the least effective method. That was already designed around for coercion. So we providers were taught to talk about the most effective methods first. Well, if we're doing that, then that means we're coming as a provider and we're deciding what's the most important thing for that young person versus hearing from them what they feel is most important. Maybe the most important thing for them is not that they're using the most effective method because it's something they have to have a procedure. Maybe the most important thing for them is they want to use something that they can do themselves, or they want to have a period every single month, or they don't want to have a period. And so we really have shifted away from that over the years to really focus on what we call shared decision-making, where we are, again, facilitators. So when a young person says, yes, I want to be on birth control, we say, okay, well, there's lots of methods out there and they all work really well if you use them correctly, and we can talk about the correct use of them. And these are some of the things you should be thinking about that birth control can do. Some of the methods can change your period, where you may not have a period after a year, or you might continue to have your period every month, or your period might be a little heavier. So what do you want your period to be like? Thinking about that. Some methods you have to use every day. Some methods you use once a month. Some methods you can come in and we do them and you don't have to think about it at all. What feels important to you? So really asking those questions of young people around what feels important to them. We're guiding that with the information, but they are really deciding, and then we can choose the methods and talk, but they are really choosing that.
Then Dr. Yolanda Evans says, thank you, Dr. Mays. Question, advice on shifting conversations amongst colleagues who tend to assume all youth should avoid parenting.
Yes, I talk about this a lot. So, you know, when I start with these conversations, the first thing I like to lead with inquiry and wondering, so why are people, you know, do they feel that way? And I want to hear some of the things that come out. And a lot of it is what we have been taught in the national narrative. And so when we think about young parenting, it is a political narrative in the same way that abortion rights are a political issue. And parenting has really been politicized in the United States. So when we look at how it has been so politicized, but it also has been paired with restricting resources, restricting support from young people to then support the political framework, right? So if we can report that young people drop out of the high school dropout rates if you become pregnant, the poverty rates if you become pregnant, the issues that maybe your child may have development issues because of the environment, because they're becoming pregnant. But we're not looking at how we withheld support from young people who were pregnant, how we transferred young people from the school system, from the traditional school system into either no school system or a pregnant and parenting school system that doesn't focus on education. And so then we wonder why people don't have their high school diploma. So again, we want to look at kind of take a deeper dive into the systems that were created to support that political narrative and what could happen if we actually change that system. So let's maybe look at some programs, some best practice programs that are looking at putting back those resources. So how do we resource young people who choose to parent? How do we support young people in the educational system and continue their education, and to really look at what can actually happen when you're actually providing that support? So I guess the first thing I would do is having a conversation and really interrogating where that narrative came from.
And Dr. Annie Hoops sort of tags on to that. She says, just yesterday, I had a pediatric colleague mention her plan to, quote, convince her 19-year-old patient to get a LARC because she had used emergency contraception twice in the last year, and trying to provide education / self-reflection without being condescending to my colleague.
Yes. Yeah, I love that example because, when we look at using principles of positive youth development, which is really drawing out young person's strengths, I hear a lot of strength in that. So I hear that young person used emergency contraception twice, right? So they knew that they could go to get EC. They used EC. They were actively trying to prevent pregnancy. Emergency contraception is a form of preventing pregnancy. Maybe it's not a highly effective method, but it's better than nothing, right? So that person came in twice. So how can we then talk about, okay, having a broader conversation around, it sounds like you're trying to prevent pregnancy. What are some things that we can do to help you to do that? So again, not us choosing the LARC for her, but how can we draw on her strengths of coming into the clinic to use EC and then having a conversation about her pregnancy intention. So I love that example. And that comes up a lot.
Dr. Amelia McClelland says, I would love to hear about how to help colleagues support patients not only with the right to not be a parent, but also that right to have a child. As Dr. Evans noted, some people assume all youth should avoid parenting.
Yes, that's right. And again, if we're really believing in and incorporating principles of reproductive justice, it also includes supporting young people who choose to parent. And also us interrogating our assumptions as individuals, as physicians who've gone through our medical training. Why are we holding judgment against this young person who says that she wants to have a child? So if she's saying that she wants to have a child, for me, what I see my role as a provider is, how can I help her to be successful in that? What is it that you need? Okay, you want to become pregnant. Let's talk about that. What are some things that you're thinking about to be successful? What feels like success to you? Have you, let's help you to be successful in the ways that you want to be successful. And if we look back at the data, if we look at the studies that have been done, talking to young people about parenting, they want to finish school. They want to have a job. Many of them want to go on to college because they know that having a higher level of education also equates to having a career that will pay them enough money to be able to parent their child. They want those things. So how can we support you in those things versus us saying, you can't be successful if you have a child at a young age, because we also know that young people who don't parent, who have a college, who have a high school diploma, who go on to college, it does not ensure success. We know that. We see that all the time for Black and brown young people. We know that having a college degree does not mean that you're going to be successful. It does not mean that you're not going to be in poverty. So, but again, that political narrative has just been really solidified around young people who are choosing to parent. But how can we also use that shared decision-making principle as it applies to young people who want to parent?
Personally mind blown by that commentary. But Dr. Graham, so bear with me, I'm gonna just read, actually, oh no, this is a different person. So helping adolescents to make timely decisions and access pregnancy care has been a problem. When we started the first high school clinic in Washington State in 1987, after the first year, we found that girls who were diagnosed with a pregnancy were not making a decision about how to manage that pregnancy until the end of the second trimester, in spite of regular contact with the clinic nurse practitioner. They were not getting enrolled in prenatal care or deciding to terminate the pregnancy. So we started to ask the girls to bring a trusted adult with them for the clinic visit within 1 to 2 weeks of the diagnosis. After a year, just doing this dramatically improved their getting health care for managing that pregnancy within the first trimester. The question is, what other systems have you found that improve the access to the pregnancy-related health care that teens choose? Are peer counseling systems helpful?
I love this. I love the intervention you all did, actually. I'm like, I like that a lot. And it's making me think about several things. So I was a school health provider for many years. About 10 years of my career, I worked in school-based health. So I have a very love for school-based health centers and school health. And I'm hearing a couple of things here. One is the importance of having trusted adults in your life. So the school-based health center is such a remarkable place because that is a space where young people can access healthcare services with a trusted adult independently, and it feels very, very safe and private with that provider. That's the design of it. So we hope that it's that way. And we know that the medical space, the medical provider can't do all of it. Right. So we know that they serve one part of that young person's life, but that young person has an additional part of their life outside of school, their personal life, their home life. So who are the trusted adults in their lives outside of the medical community, outside of them seeking healthcare services? I think that is so important for us to know who are the trusted people in young people's lives. Who are those trusted adults? One thing that I often do when I have a young person in clinic with me who's pregnant, I ask them, who are you going to tell about your pregnancy? Who are the people you talk to when you need something? Who is someone that you could confide something? If you had to tell a secret to, who would you tell it to? Because that lets you know who the trusted people are in their lives. And I don't even say a trusted adult because they may not mention an adult. Right. So we also know that some young people don't have any other trusted adults in their lives outside of those in the medical space where maybe they're seeking services. That shows us that there's a gap, and maybe we need to now connect them to our social services or our social worker. If we have a health navigator, another trusted adult who can be that kind of secondary person. So I love the idea of bringing in kind of a trusted adult into their lives, because that person kind of serves as a mentor outside of the medical space that can continue to talk to them about their the pregnancy intention, whether they're going to continue their pregnancy, not continue their pregnancy, getting them into prenatal care. And then the other thing is kind of traversing the medical system. So we do that in the clinic space. We only have so much time to do that. But we all know, because we all access the medical system on our own, that it is a difficult system. We are dealing with a difficult and confusing system. And we also know that young people receive disparate care in medical spaces in general. We do it well as pediatric and adolescent providers, but when young people go to seek general care in emergency rooms and urgent cares, even in OBGYN offices, they can receive very disparate care because sometimes people don't know how to approach young people, or they don't understand the disposition of young people. And then there's another layer of stigma on young people when they are pregnant. So young people get lots of looks. I think I've told this story about so many times where our young people in our groups have told us that they'll be in Target or in the grocery store buying groceries or buying basic needs for their young people, for their child. And the looks that they get from other people in the store, they're highly stigmatized. And that often can cause young people not to want to seek services outside of their pediatric and adolescent services.
I think Dr. Kieran has a question, so I'm going to let her unmute.
Yeah, I do have a question, and I apologize because I think this might be the last question. But a lot of what you talked about today has really focused on, mothers, or more specifically, people who have a uterus. And so I'm just wondering, what opportunities are there to engage prospective fathers, people that are part of the wider family, the broader community, particularly including those who don't identify as, cis, straight women? I mean, how do we get everybody on board with this?
Yes, I will talk about this in two ways. So first, we're talking about contraceptive care. So we know that we were talking about preventing pregnancy, we want to be talking about that globally with young people. So we want to talk about that with cis young people, non-binary young people. We don't want to assume I have done lots of contraceptive care for young people who are trans identified, who have a uterus and don't want to suppress what's happening with their uterus because of their identity. And that is and so again, when we lead with a shared decision-making principle, where we're asking young people what feels important to them, we take out the assumptions of why they're using a method. We take out the assumption that a method is being used to prevent reproduction. Maybe the method is also being used to prevent what's happening in puberty, or that young people are using a method to prevent reproduction, but they also they're interested in sexual experiences with regardless of gender, of all genders. And so when we take out our assumptions, we can really be open to hearing what is important to our young people and start our conversations from there. And then the second piece of that is how we engage young people, partners, fathers, however young people define the other person that they may be parenting with, or that they are having a child with. I always like to hear how young people, number one, how young people define who that person is. Are they calling that person a partner? Are they calling them their boyfriend? Are they calling them their girlfriend? Are they choosing to parent on their own? So we also know that probably about 50% of the young people that I care for want the partner to be involved, and 50% do not. They have decided, we were together, maybe we weren't, but I'm going to be parenting on my own. So again, just leading with that openness and also creating a space for partners. So our Young Mothers Rising program has been in existence for 4 years now. And now we are in the space where we're talking about how are we going to bring in the other parent, a parent, or either a co-parent or a partner, and how can we provide support for our young partners. We've decided that we want to create a space for them, because we want to keep our young mother space just a protective space for our mothers. And we are working with our mothers to figure out how they would like to have them incorporated, if they want them incorporated, what feels important to them too. So this is all really leading back to the principles of positive youth development, which is how we partner with young people on services, on programs that are really designed for them. It's a slower process. It's one where we have to take, we have to be kind of in the passenger seat and have our young people in the driver's seat, and we're really partnering together to provide the services that are designed for them.
And with that, I just want to thank you again, Dr. Mays, for sort of this incredible lecture about ways in which we can be more humble in the care that we provide to our youth and adolescents and young adults as well. It is just a real privilege to hear you talk. As a couple reminders, they've been in the chat already, but please share your thoughts on today's webinar by answering our survey, and then also complete the survey to improve our webinars. We will be doing this again in 2023. We'll have a whole new slew starting in March, so stay tuned for that. And then for those that are interested in accessing our Equitable Care Toolkit, you can find it in PDF format, but you can also order a hard copy, and those links are in the chat as well. And Dr. Mays, again, I know that we're not doing this in an in-person auditorium, but just a standing ovation for such an incredible talk. Thank you so much.
Thank you so much. Thank you so much for having me. And I'm great to have our Washington colleagues, and thank you so much.
Yes, have a wonderful morning and have a wonderful holiday, everybody. Yes. Whatever that looks like to you. Take care.
Take care.
Good morning.